Thank you very much, Dr. Shah. First of all, before I will start, I would like to thank Professor Knecht very much for inviting me and, of course, for organizing this symposium. I did this also several times, and I think it's tremendous what you did here, and congratulations to you. So I like to discuss some aspects on the management of lymph node metastasis. And of course, we have this short list from our chairman, and I will focus on some of these different aspects, and will start with nodal factors affecting prognosis, and here, of course, with the discussion for prognostic markers. There are a lot of prognostic markers in the field of head and neck cancers. In our group, we did also some research on this and published some papers, but mostly with only small numbers of patients. So I think that the future way has to go on with the analysis of the literature and to have an overview what is really known in the literature. So I will focus first on a meta-analysis of the prognostic significance of perinodal spread in head and neck cancer patients. And we could show that the study methodology allowed enrollment of only 9 of 115 published papers. But if we analyze these 9 papers, we could show that perinodal spread is a doubling risk factor that reduces the 5-year survival by univariate analysis. The conclusion of this paper was that the creation of international standards for assessment of micro and macroscopic perinodal spread is very important, and of course this challenge should be approached by carefully designed multi-center studies. Another meta-analysis was the analysis of the significance of different matrix metalloproteinases for nodal disease in head and neck cancer patients. And here it was obviously that there is a huge heterogeneity of the data collection, especially of the different immunohistochemical staining methods and also statistical methods. So the results of this study were that the metalloproteinases 2, 3, and 14 were found to possibly play a role in the metastatic behavior of head and neck cancer. But when we go on with further discussions on the topics of matrix metalloproteinases, as a first step, we have to focus on a standardization of immunohistochemical staining procedures and the evaluation protocols. These are very necessary because all the different papers on metalloproteinases are sometimes a little bit problematic. These are the prerequisites to achieve comparable results for further evaluation. Now, we had a panel on diagnostic imaging, the session 13, but I would like to focus on one special topic, on the topic of sentinel node biopsy in head and neck cancer. Of course, in the meantime, there are a lot of different data in the literature, but first I will start with our own data, and I can show that the extirpation of only one sentinel node, the sentinel node number 1, the hottest lymph node, is for head and neck cancer not representative. Lymphatic mapping with the detection of the sentinel nodes 1, 2, and sometimes 3, so of the 2 or 3 hottest lymph nodes, confirms the concept of the selective neck dissection with the removal of the main metastatic level. So the question arises, shall up to 3 tracer accumulating lymph nodes be extirpated regularly, or is it a question of further limiting selective neck dissection, like Wolfgang Steiner described this, for only the dissection of, for example, the level 2, 2A, and 3? Then there is a meta-analysis published in Head and Neck 2005 from Paleri and co-workers. And this was a systematic review and diagnostic meta-analysis of the published literature regarding until December 2003. They analyzed a total of 301 patients with oral cavity primary tumors and 46 patients with oropharyngeal primary tumors from 19 articles. They included this in the meta-analysis. They could show that the quality of injection and thus experience of the examiner plays an important role for the exactness of this technique. The complex architecture and distribution of the lymph vessels in the head and neck lead to a high risk of possible pitfalls, and the B-mode sonography plus fine needle aspiration cytology, published very extensively by Van den Brekel, has the same specificity and sensitivity depending on the examiner. However, it is non-invasive. So I think this is a further point of discussion, the sentinel node concept, but up to now it is definitely not a solution for the N0 neck. Now I will focus on the management of the positive and also the negative neck, and of course mostly on the surgical management. In the year 1906, George Cryle described for the first time the classical radical neck dissection. So in the meantime, we have 100 or 101 years experience. So the question arises, is this time enough for standardization of, for example, indications for these different neck dissection forms, and also, of course, for the modified radical neck dissection? And if we discuss now the different indications, we will start with the positive neck. There are some institutions, they do regularly a radical neck dissection. Other institutions, modified radical neck dissection, more and more also selective neck dissections, or sometimes I will say a super selective neck dissection. But what is the role for radiotherapy in these patients? We don't know this exactly enough. Shall we indicate a radiotherapy in an N1 situation or N2 for two lymph nodes? When is the best indication? So this is a question we have to discuss it. Then, of course, a little bit more confusing, the N0 neck. First, we heard this from the group of Amsterdam, wait-and-see strategy. I think this is a wonderful technique. If the patients will come again and you can do the ultrasound again and again, then again, selective neck dissections, sometimes modified radical neck dissection. I think there is not really a place for radical neck dissection. So if we compare the different countries all over the world, I think definitely there cannot be standardization for indications because, for example, the follow-up concepts are totally different. If you treat a patient in Nairobi, it's totally different from a patient in Frankfurt or so. So when I visited some of these countries, first I thought, oh, they have to do such a selective neck dissection. But you understand this, if you see the patients, sometimes it's necessary, of course, to treat this with a radical neck dissection. So worldwide, there is not really a standardization. So what's in Europe? In Europe, it's definitely the same. A lot of different strategies. So I think also Europe is not a standardization. But now let's focus on Germany. And I think I will ask, what is the technique or the indications for the different neck dissection forms in Germany? And there, first I have to point out, in my eyes, an outstanding symposium, 1992, it was organized by Wolfgang Steiner on the N0 neck. And there were a lot of very, very important speakers, and the discussions were summarized in the European archives. And so we can discuss what happened during the next, for example, 10 years or more than 10 years. A lot of German chairpersons were in this meeting, and I think was there now a consensus? This is an important question. And so what did we do? We analyzed in a questionnaire data collection from 39 hospitals the different approaches for neck dissection in an N0 situation. And we could show that there is definitely no unique treatment concept of the surgical neck treatment in Germany. And what we have to focus on is the necessity to develop stage-associated treatment concepts of the cervical lymphatic drainage. So I think also in Germany there are a lot of individual concepts, but not a consensus on the strategy in one country. I will focus a little bit on the post-chemo radiotherapy neck. And this is, I think, a very, very important question, especially if we recognize that more and more patients will be treated with radiochemotherapy, and then it is not a question that these patients are only treated by the radiotherapists. These patients has to have the follow-up from the ENT doctors and, of course, the discussion for the neck dissection in cases of doubt. In the year 2000, Steensen and co-workers published in the archives that the neck dissection for patients with N2 or greater neck disease after chemoradiotherapy is necessary to eradicate residual disease, and the complication rate of these selective neck dissections after the chemoradiotherapy with hyperfractionated radiotherapy is low. Selective neck dissections are technically feasible when performed within the window between the acute and chronic chemoradiotherapy injury from 4 to 12 weeks. So in another paper, there are, of course, some papers on this topic. It is from the last year, also in the European Archive published, and they could show, the group on Simon, that the presence of viable cancer cells in radiated neck nodes is a novel prognostic marker for disease-specific survival in patients treated for squamous cell carcinomas of the pharynx with advanced neck disease. What we do in Germany now is, you heard about the study, the HEART protocol from Volker Budach in Berlin, and in this study we had a special group of some centers in Germany, and we tried to analyze in such a translational research project the presence of malignant tumor cells in persistent neck disease after radiotherapy, and I hope that we can give some answers on this very important issue in several years. So let me close with possible future strategies, and of course there are some of them, but I will focus on two of our own projects. The first is the translymphatic chemotherapy, and the second is magnetic drug targeting. Let me focus on the translymphatic chemotherapy. I was involved in a phase 3 placebo-controlled study in advanced head and neck cancer using intratumoral cisplatin epinephrine gel application. And we could show in this group that from 57 patients, 14 patients, 25%, showed a tumor reduction, a reduction of the tumor volume. But there was one side effect, and I thought that this was very interesting. It was also a volume reduction of neighboring lymph nodes. And the question arises that, is there a possibility of drug targeting utilizing CDDP conjugated block copolymer tracking systems for such a translymphatic treatment of draining lymph nodes? And we have a collaboration with Professor Antonietti. He is a director of colloidal chemical aspects in the Max Planck Institute in Berlin. And he could build up such copolymers. And I think that I will shortly explain our setting up of the experiment. We have an animal model. It's a New Zealand white rabbit with a VX2 carcinoma. It's an undifferentiated squamous cell carcinoma of the ear, of the auricle. And we removed this squamous cell carcinoma and could analyze how is the treatment, how is the therapeutic value of such colloidals and these carrier systems, including cisplatin. So it is a drug transportation system from the healthy skin directed to the lymph nodes. And this is really a translymphatic transportation system. And we could show that it is an eminent effect of these very low dose cisplatin gel in the lymph nodes. And it is probably a way for the future to go on in a very early disease. So if you treat the neighboring lymph nodes, probably the situation for occult metastatic disease, I think this is the most important question. Probably this will be a possibility to go on in this. Now we have some other steps. We built up special polypeptides, and I think that the transportation system can be better in the future. But I will only show you that the technique of translymphatic or intralymphatic chemotherapy may be a good topic. Another thing is the magnetic drug targeting, and I think this is also interesting what we heard about the diagnostic approach for the lymph nodes. And the concept is that there are external magnetic field concentrates, ferrofluid particles in these lymph nodes, followed by application of external shock waves to unhinge the chemotherapeutic agent from its linkage, which results in an increase of local effectiveness. And again, our first results are very promising, so that I will only focus. There are some other treatment modalities, of course, very early reports, but I think we can go on with such ways to follow this. Thank you very much for your attention.